Okay? Did everybody see that I put the handouts on Blackboard yesterday? So, and I did put your PowerPoints up because y'all were having withdrawals. So, we'll just have to kind of look through those. But let me say something though about the PowerPoints. Remember that just because you've got the PowerPoints doesn't mean you don't need to be here, or doesn't mean you don't need to take notes.
Or do your reading.
Yeah, or do reading, because all those things are really, really important as an addition, okay? All right, let's talk about pregnancy. Now, as I go through this, I did last year, and it's kind of fun, just little odd little facts. I'm going to be throwing in these little Guinness Book of World Records type things. I'm not testing you on those. They're just fun little things to learn about, okay? This one, we'll talk about, what I've done is we'll talk about this right before you go to break. Okay, that's how I've done this. I'm just going to talk about the first wife of Fyodor Vasilyev, that's I guess how you pronounce it, from Russia. So we'll talk about him when we come back from break. Okay, odd little facts no one tells you about pregnancy. That you could be pregnant for a whole year. Okay, most pregnancies last how long? 9 months. And doctors are likely to induce you if you go any longer than that. This is the second slide. These are probably not in your, they're not in your student edition, because these are just little fun things. These are just things I just want you to listen to, unless you just want to write them down to challenge your friends or whatever. This is not testing information, okay? This is just fun stuff. Okay, so we do know that if pregnancy goes too long, they will probably induce you. That being said, it is possible to be pregnant for a whole year. The world's longest pregnancy lasted 375 days.
Oh my God.
Wow.
375 days. The baby was only a little under 7 pounds.
Really?
Now, because what happens is, and we're going to talk about this, is that at a certain point, that placenta, which has been feeding the baby and supplying it with nutrients, stops.
Mm-hmm.
You know, it says, I've done my work, I've been here for 9 months, and I'm not going to do any more. And so what happens is that they essentially are going to stop growing at that point. Now, hair and nails will still grow, and that's why when you've got babies who are born past 38 weeks, 40 weeks, they look like little old men. They got long hair and long nails, and they're kind of wrinkly and just not very attractive. But that certainly puts a new perspective on being a few weeks late. So 375 days. Have you ever heard people say you've got the pregnancy glow? Yeah, you really do glow, like a glowworm. You really do glow. It's a common expression, and most people chalk it up to the woman's excitement about being a mommy. But as it turns out, glowing skin is a very real thing for pregnant women. You really do glow. While you're pregnant, the amount of blood in your body increases by 50%. And so all that extra blood ends up showing through the skin, and particularly the cheeks. So people say that to you, like Amanda looks like she's glowing right now. She actually looks like she's about to fall asleep. She's tired. Right. She's got an aura. She's trying to run after Wyatt and be pregnant at the same time. Right? I said you're trying to run after Wyatt and be pregnant at the same time. Yeah, it's a little much. Yeah. But on top of that, on top of the fact that you can see all that extra blood through the cheeks and through the skin, your body produces more oil, and so you're kind of shiny at the same time. So you've got a softer, shinier red appearance, and that makes you look like you're glowing. Okay, your sense of smell and taste becomes superhuman. And I put like Superman or Superwoman, however you want to say it. Did you know that? Your sense of smell increases drastically, as does your sense of taste. And why do you think that is? They mentioned it in this video. Why do you think that our sense of taste and smell? Because of safety, because things that you don't need to eat. It's a protective mechanism. It's a protective mechanism because it helps you avoid toxins. So that's why some women can't stand the smell of certain things. That's their body's way of saying you don't need to be around it, which I think is interesting. So like cigarette smoke, alcohol, some people coffee makes them nauseated or sick, and all those things can be, and especially in great amounts, detrimental to the baby. So it's interesting that our body can do that, I think. Okay, the next thing, you don't really need to eat for two, although the thought is nice, right? We don't really need to eat for two, despite widespread rumors that say pregnant women need to gain all the weight they can in order to birth a healthy baby. And we all talked about this in my sim the other day. I think I gained 70 pounds with Ben. And we were talking about how much everybody had gained in sim the other day. The truth is that most women who are an average weight only need to gain about, or only need to consume 300 extra calories a day. That's not much. That's equivalent to 1 serving of yogurt and a half a bagel. 300 calories. Most women only need to gain about 25 pounds throughout their entire pregnancy. And I found this, I thought it was cute. It said, they say, of course, if you happen to be at the buffet and you're having a tough time resisting the dessert section, go ahead and snack a little extra. No one will give a pregnant woman a hard time if she picks out. Alright, so only 300 extra calories, that's not a lot. A serving of yogurt and half a bagel. Alright, your feet will grow an extra shoe size. Did you know that? They really do grow an extra shoe size, and they don't typically go back down. They may shrink a little, but not much. And if you're wondering why your feet get so big when you only gain 25 pounds, it has to do with the excess pressure on your feet paired with the relaxed ligaments. Okay, there's a substance, there's a hormone called relaxin that's secreted, and it relaxes. Its purpose is to relax the ligaments around the pelvis so that your pelvis can stretch. And if you've been pregnant, you know that feeling of your pelvis feeling like it's breaking apart, stretching. But it stretches everything. It stretches the ligaments in your feet as well. So that's why, unfortunately for your shoes, your feet start to lose their arch and they start to stretch out on the sides. The flatter, wider shape of your feet will probably be temporary, but it can end up being permanent. But it lets you buy more shoes. Right. Okay, number 6, a father might really show signs of pregnancy. You know how they say that the father is showing sympathy, pains, or whatever? Did you show that, Jason? Oh, y'all don't have a dog. Y'all have a furry dog, right? He has a furry child. That's right. What about you, Joey?
No.
You did not show? You don't have sympathy? Jeff, did you show sympathy signs? Jeff did. Did you gain weight and everything? You did with her? Yep. It is common for a father-to-be to start gaining weight, get morning sickness, and even feel cramps in their lower abdomen. There is a French word that they call it. It's called Couvade syndrome, C-O-U-V-A-D-E, Couvade syndrome. And it comes from the French word couver, meaning to hatch. So, just some little interesting facts that you might want to share with some friends, okay, about pregnancy. I liked the video or the DVD, because one of the things that it does is it takes you from the very, very beginning, what actually happens from conception. And a lot of this stuff you probably already know, but let's just review how this occurs, okay? All right, so we know that the process of conception, the actual process of conception depends on a single sperm and an egg. And remember that he said in the DVD that there is no prize for second place, right? only one sperm, it only takes one sperm to fertilize the egg. And we're going to talk about conditions later on where that are, they're called hydatiform moles, where more than one sperm attached to the egg, go into the egg, and it's not a good situation. But we only need a single sperm and an egg. In order for conception to be complete, 4 things have to happen. The first thing is that you have to have an egg and a sperm, right? Those are called gametes. You remember that from anatomy? You have to have an egg and a sperm. The second thing is that the woman has to be able to ovulate. That egg has to be released. And a lot of women have trouble with that. They have trouble with ovulation. They don't ovulate on a regular basis. Is there anybody in here that's like that? Yeah. I was like that for a long time. I never knew when my period was going to be because I never...
42.
Huh? 42, yeah. It's a long time. I mean, it takes sometimes that you just never know. So you have to be able to ovulate. That egg has to be released. The next thing is those gametes have to come together. They have to become a union. They have to result in an embryo. So they come together, the egg and the sperm come together, they join, and they form an embryo. And then the last thing that has to occur is that it has to be implanted into the uterus. Now, unfortunately, there are times when that embryo is implanted elsewhere. And you've heard of those things. Those are called ectopic pregnancies, where they're implanted in the fallopian tubes, in the abdomen. I don't know if you've ever heard of ectopic pregnancies in the abdominal wall, but they can. So they have to be implanted in the uterus. So this is a perfect world up here, right? This is our perfect world. Unfortunately, that it doesn't always occur like this. The majority of the time it does, but we're going to look at some conditions that where these things don't occur. This is a picture. It's an old picture, but I like it and I still use it because it's pretty. It's a big picture and it shows all the different parts. A lot of this you should remember again from anatomy and physiology. The top one, of course, the left one is the sperm. The right one is the egg. Did you like that picture on the DVD where all the looked like stars twinkling almost, all the little sperm going up? Okay. 2 things are very important to remember, and when you're counseling someone about getting pregnant, this is extremely important to teach. The first thing is that an egg that is released is only fertile for 24 hours after ovulation. Okay? An egg that's released is only fertile for 24 hours after ovulation. Okay? Now the second thing that's important to remember is that when a man ejaculates, there's a lot of sperm that's released, somewhere between 200 and 500 million sperm. That's a lot. 200 to 500 million sperm. Transit time, and I believe he mentioned this also in the DVD, that transit time can be anywhere from 5 minutes to 4 to 6 hours. So let's think about this. Think about all these times that I'm telling you in your mind. And then the biggest catch of all is that sperm are viable for 2 to 3 days. Sperm are viable for 2 to 3 days. So what does that tell us?
People think that there's sperm, but it's actually still alive and can still go up into
Right. Okay. Hope just said, people think that they're safe, but they may not be. You could have intercourse on a Sunday and get pregnant on Tuesday. You see that? Or on Wednesday. But only if you ovulate within those 2 or 3 day time. Okay, so you see how some people who are trying to get pregnant, sometimes that's a lot of work trying to get. Have you ever noticed that people who are actually trying to get pregnant, it's a lot of work because you have to get all those factors in. People who don't want to get pregnant, it just they magically somehow get all those factors in place at the right time. So.
And that's why you have all these people in bars who are like, that's not the baby daddy.
Yeah, yeah, that's right. That's why you're very right. Deanna just said that's why it's hard sometimes for people to figure out who the baby daddy is. So.
But I don't.
Okay? So, but anyway, it's very, very, very important when you're thinking about teaching people that those are some times and stuff that you need to really remember. Okay? All right. Fertilization. The act of fertilization. So when the gametes come together, it occurs typically in the outer third of the fallopian tube. So if you can picture this in your mind, the egg is released from where? From the ovary. It travels down the fallopian tube, right? Travels down the fallopian tube. And at the very bottom, that's where the sperm has swim in. Okay? One of the 500 million sperm manages to swim up there. And that is where they're fertilized, in the outer third of the fallopian tube. Okay? Then that embryo that is fertilized has to be implanted. Implantation does not typically occur until 7 to 10 days after fertilization. So it takes a while. And women who are trying to get pregnant, who are really paying attention to what's going on, may notice when implantation occurs that they start to spot. They start to have a little bit of spotting. Because what's happened is, for implantation to occur, that embryo or that zygote, some people call it a zygote at that point, it burrows itself down into the endometrial lining of the uterus. So it has to burrow itself down. And I think they showed a picture kind of that on the DVD as well, where it's burrowing down. So when it is burrowing down, it can cause a little bit of bleeding. It can cause a little bit of spotting. So that is at the moment of implantation. So that occurs about 7 to 10 days after the two come together and they are fertilized. Okay? Now, the endometrial lining of the uterus. Okay, that endometrial lining. And remember, what do we typically, on a monthly basis, we have a period, right? We go through menses, and what is that? What is the menses? It's the shedding of the lining, right? Because we don't need it, because there's nothing implanted there. It's not needed because there's no fertilized embryo or zygote that has burrowed itself down into its lining. So if there's nothing there, if nothing has burrowed down into the lining, then it's shed, and we have a period. Okay? Now, when it burrows itself down, that endometrial lining starts to provide nutrients to keep it alive until a placenta is formed. Okay? The endometrial lining provides nutrients to the embryo until a placenta can be formed. Okay, so does everybody understand this process? So the egg is released, it travels down the fallopian tube where it meets up with the lucky sperm, the one sperm that has made it more farther than anybody. They join together, okay? They kiss, 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 and they join together, and they form, and they fertilize, and then they burrow themselves down into the endometrial lining. And that's what provides them food until things start to grow. All right, now, as the baby grows, it starts to form all these different things. Now, did I put this little triangle picture up for you? Okay. The 3 primary germ layers. Okay, 3 primary germ layers. Let's look at these. The 3 primary germ layers. As it starts to grow, it starts to form different parts of the body, right? It starts to turn in on itself. You remember that picture? It looked like a donut that was collapsing on itself, and it starts to form all these things. I think it is amazing how you can go from a joined little zygote or embryo to form a baby. Isn't that amazing? It's just amazing to me. That's why I like OB so much. Okay, the germ layers. There's 3 primary germ layers. Did y'all talk about these in anatomy and physiology? Some of you did, some of you didn't. Okay. It's been a long time. Okay, so let's review them. All right. The first one is the ectoderm. Okay, the ectoderm. And so if you see at the top of your triangle, the ectoderm forms different things. It's responsible for developing the epidermis of the skin, the glands, the nails, the hair, the central nervous system, the peripheral nervous system, the lens of the eye, tooth enamel. Can you believe that? Tooth enamel. And the floor of the amniotic cavity, which is we're going to talk about in just a minute when we talk about the placenta. Okay, so the ectoderm is responsible for those. And how it decides those things, I don't know. It just happens to be that the ectoderm is responsible for those different things. All right, the mesoderm, which is on the left side of your triangle, the mesoderm is responsible for a lot of the hard things, the bones, the teeth, the muscles, the dermis of the skin, so the outer layer of the skin. And then connective tissue, the heart, the spleen, and the urogenital system. See that? And then the last one that forms is the endoderm, and the endoderm is responsible for the epithelium, so the inner layer of the skin, the epithelium of the respiratory and the digestive tracts, the oropharynx, the mouth, the liver and the pancreas, the urethra, the bladder, and the vagina. Now I will go ahead and tell you that when on your next test, there's I think there's one question, I don't think I did any more than that, but there's a question that says which of these layers forms the teeth or whatever. I don't remember if it's the teeth, but I'm just saying. Okay, so you need to really study those different layers and what they form. Okay? So all the tissues and organs develop from those 3 layers of this embryo. All right, now, 2 membranes form, and this is very important. And I've got a little model here that I'm going to show you. Okay, 2 membranes form. Okay, the chorion and the amnion. Okay, the chorion and the amnion. All right, the chorion, or the outer cells, become the fetal side of the placenta. They cover the fetal side of the placenta. Okay? It contains the major blood vessels that branch out over the placenta. Okay, so the chorion covers the fetal side of the placenta, and it contains the vessels that branch out over the placenta. Okay. It also contains, and this is going to be very important later on, it also contains chorionic villi. Chorionic, chorionic, villi, villi, chorionic villi. And chorionic villi are little finger-like, hair-like projections that are on this. Okay? Actually, they're on this side. Flip it. Okay? Finger-like projections that are on the outside of this chorion, and it sticks those little, they're like suction cups, they're like octopus legs, and they suction to the side wall of the placenta. Now later on we're going to talk about the fact that those villi can be snipped off during pregnancy to be tested for genetic purposes. Like when they're doing genetic testing to see if they've got some kind of problem, what they'll do is they will go in and they will actually snip off part of the chorionic villi, and they can send those off for testing.
So it helps the placenta attach to the uterus?
Yes, to the sidewall. Right. Those villi are what break when right before the placenta is born. You know, this has to come unattached from the sidewall of the uterus. This has to become unattached. So what happens is the contractions cause those villi to break off and come apart so it can be born. Okay? All right. The second membrane is called the amnion. So you've got the chorion and you've got the amnion. The amnion forms, what does it sound like? The amniotic sac. And it covers the umbilical cord. Now, I'm going to kind of flip these two layers. I want you to see these two layers. That's why I like this model so much, is because it shows you the two different layers. If I can get my strings untangled. Okay. All right. See, there's two, this chorion and amnion. You see the two different membranes here? Okay. So when they grow, they're forming, what they're doing is they're forming the placenta. And eventually what's going to happen is they come across each other and they stick together to form, they go around the baby, they grow around the baby. So they come together to form the sac. Okay? It will eventually, the amnion enlarges as the baby grows and eventually comes in contact with the chorion. See how they both come together? Eventually comes in contact with the chorion. They come together and they surround the fetus. Okay, so let me put the baby back inside so you can kind of see. I'm getting back in there. I know he's not born with a diaper on, but and see, here's my my umbilical cord that's attached to him. See, it's inside, floating around with him. So see, here's my little sack. Okay. So now, see, what happens is that this side, a lot of people call this the rough side. This side sticks to the side wall of the uterus. Fall out. It's sticking. He's inside his little sack floating around, right? And eventually when the water breaks, the baby's born, this comes unstuck and the whole thing is born. You see that? Okay, so I like the way that I like this model because it shows those two levels, those two membranes. Okay? Yes, sir. Because it's going to. eventually they come together. All you need to remember is that there's chorion and the amnion. They both come together, and then they both flip and attach the baby. Yeah, that's all you really need to remember. Okay? So you got chorion and an amnion. Okay? See that? All right. Now I'm going to pass this around so you can look at it. Okay? And then while you're looking at it, I'm going to show you a picture of a real There you go. So you see that? And let me see this for a second. Adam, you'll be able to see too that this has a layer across it you'll be able to tell better when you see it. Okay? All right, so here's a sample. Here's a picture of a placenta that's born. See, this is the part that was attached to the wall of the mama. See that? And from that chorion develops those two membranes, or the chorionic membrane, and it grows this way, comes in contact with the amnion, and they stick together to form that sac. Okay? So that's a nice picture of that. Here's a picture. Y'all see this? Now, remember him talking about the yolk sac? What was this important for? Nutrients, right. Right. And I hate to break it to you, but that's what the yellow is in the egg. Y'all do realize that, don't you? I don't know if you. That's a yolk. It's a yolk. That's what it is. It's a yolk. It was to provide the nutrients for a chick if the chick had developed.
Nutrients from the yolk sac and the endometrium.
Exactly. Yeah.
And where do they take their cord blood from?
The cord blood? They take it from the cord. The actual cord. Yeah. All right, now let's talk about the yolk sac too while we've got this picture up. The yolk sac forms at the same time that the amnion is developing. The yolk sac forms at the same time that the amnion is developing. And it acts as a liver. And one thing that we will talk about is that the fetal liver is not mature at birth. That's why babies become jaundice. Because their liver is very immature. Okay? So that's why babies become jaundice. So the yolk sac acts as the liver. It aids in nutrients, sending nutrients and oxygen that have diffused from the chorion through the cord to the baby. Okay? It acts as, let me see that for 1 second. It acts as the fetal liver. It aids in nutrient and oxygen production. Okay? That fuse through the chorion. Now let's look at this for a second. Let me show you this for a second too. Okay, remember I said that this rough side, this side right here, is stuck to the mama, right? Okay? Those little hair-like villi don't just stick it. They're also drawing nutrients from the mama. Okay? So they're drawing them through those little villi, through these vessels. And I want you, when you get this, to flip the layer so you can see the vessels. Through these vessels, through the cord to the baby. Okay? The yolk sac helps that process because it's acting as a liver. It's taking out what the baby doesn't need from the mama, which would be all those substances. And you know, a lot of people, when they say they don't realize they're pregnant, that's a very scary thing when you're talking about the first trimester. Because the first trimester is the most important time to not participate in illegal substances. Okay? Drinking, smoking, drug use, even some prescription drugs should not be taken while you're pregnant. Because what's occurring during that first trimester? They're growing, everything's growing during that time. So the yolk sac helps, it doesn't take everything away, but it helps filter out what we don't need to send through here and send through here what we do need. Okay? Now eventually, when the placenta forms, that yolk sac becomes redundant and it actually is incorporated into the umbilical cord. It actually, as the umbilical cord and the placenta are developing and growing, because before this, you didn't have a placenta. You just had those two membranes. That's all you had is these two membranes floating around, okay? And then when they come together, when the placenta forms, that yolk sac is not needed anymore because the placenta is going to take over doing everything. So that yolk sac has to go somewhere because we don't need it anymore. So it's incorporated into the umbilical cord. Okay? As the placenta and the umbilical cord grow, the yolk sac is incorporated into the umbilical cord. Okay? Another thing I want you to remember about when we're talking about the placenta growing and developing, remember, it has to develop its own circulation too. Just because the placenta is there doesn't mean it's going to work. It has to have vessels to go back and forth. And so until those vessels have really formed, it's not really going to do much of anything. So the body knows when it's ready to get rid of that yolk sac. All right. The umbilical cord. During the third week, blood vessels form. At the 5th week, the umbilical cord is formed. Okay, the yolk sac is incorporated into it. Everything becomes compressed, and then the umbilical cord is formed. And that's our transfer, that's our lifeline. That's that baby's lifeline, is that umbilical cord at this point. Okay, because everything is developed now, so now we don't need that yolk sac anymore. The placenta and the umbilical cord has formed, and it supplies all that's needed to that baby. Okay? How many veins are there? Well, first of all, how many vessels, period, are there? 3. There are 3 vessels in that umbilical cord. They're very important. Okay? And you can remember it. I always remember my stepdaughter's name, Ava. Because, so if you remember Ava, she would love to know that that's how I teach that. If you remember Ava, then you'll remember that there's 2 arteries, 2 A's, and 1 V, 1 vein. 2 arteries and 1 vein. So if you remember Ava, artery, vein, artery. Did anybody get to see a cord this last week? A couple of you did. Did they count the vessels? Did they show you how to count the vessels?
Samples of it.
And they took samples of it. Good. Okay. So it wasn't hard to tell which was the artery and which was the vein? Y'all could tell? Could y'all tell? Yeah, a big one. Yeah, the bigger they are, the easier they are. In the NICU, did anybody get to go to NICU? A couple of you got to go to NICU. You know, in the NICU, we use arterial lines through their cords. And sometimes it's very difficult to get it feed down into that artery of that umbilical cord. So we use those arterial lines. But it's interesting because you have to look at the cord and figure out which is the artery and which is the vein and poke the line down. And so that's always an interesting thing. Okay. All right, so we know AVA, one vein, two arteries. The arteries carry blood from the embryo to the villi. Remember those little chorionic villi? So they carry, remember, arteries carry stuff away, right? Away, that's how I always remember it, away. The arteries carry blood away from the embryo to the villi where they are oxygenated. It's oxygenated. And then it returns through the what? Through the vein. It returns through the vein. Okay? Now, 1% of cords, which is a very low number, 1% of cords have only two vessels. The problem with a two-vessel cord is that it suggests that there are congenital malformations. And you can imagine, because if you've only got two vessels, if you've only got one vein and one artery, there's not enough oxygen supply. There's not supply enough to form a good baby, a baby who has, it's not congenitally.
You said the arteries carry blood to get oxygenated?
They carry it away from the baby. It circulates, constantly is circulating. Blood is taken from the vein, through the vein, from the chorionic villi to the baby, and then the arteries take it from the baby to the chorionic villi to get oxygen. So it's a constant circulation. All right. At term, an average cord is about 2 centimeters in diameter and about 30 to 90 centimeters in length. It's about 2 centimeters in diameter and about 30 to 90 centimeters in length. There is a substance in the cord, inside the cord. Remember, it compressed together to form it. There's a substance called Wharton's jelly that's inside that cord. And what it does is it prevents the cord from compressing upon itself, from collapsing upon itself. So it's a jelly-like substance that's inside the cord that prevents the cord from compressing on itself. Here's another picture of a placenta with a baby attached. See this little tiny umbilical cord at this point. Got a neat picture. I think it's a neat picture. Personally.
You said
Compressing on itself. Yeah. Here's another picture. You can kind of see up here at the top, you see at the very top how it's smoother. You see that? Mm-hmm. And if you look at that that's coming around, Jennifer's got it right now, that you can see that smooth part with the vessels. And you see the amniotic sac that has come across. With the little, hey, look at his little tiny toes. Tiny toes there. Okay. Got a picture and a bit funny. All right, now occasionally this can occur. I hope you can see that. Can you see that knot? A little bit. It's hard to see it. I don't know how to make it wider. There's a knot in this cord. Let's see if I can where it's, you see it there? Yeah. You don't see it now? Yeah. Occasionally, and those of you who've had me in SIM know, or that first week we talked about this, occasionally cords can become knotted. Now, a true knot is rare. This is a true knot, and it's very rare. The problem occurs at birth when the water breaks and there's nothing to prevent that baby from floating around anymore. It starts to drop down, and as the baby is being born, a knot that was not a problem in utero, because you remember you've got all this fluid floating around, plus you got that Wharton's jelly inside it, so it's never going to become tight. It's going to be a very loose knot. You know how when you tie your shoes and it's just a loose knot? Until the water breaks and there's nothing floating around anymore. And so as the baby drops, that knot becomes tighter and tighter and tighter. And it acts as, it's like a hanging noose. And so you can have a situation where a baby is perfectly fine throughout the whole 9 months of pregnancy and die in labor because of a knot. The problem is that knots are so rare and they can't be seen on an ultrasound. Ultrasounds are used when you've got the fluid floating around. So you're not going to be able to see it. You're not going to be able to tell. And that cord, remember, can be up to 90 centimeters in length. It's long. You're not going to be able to see a knot. And it's not going to be tight. So you're not going to be able to tell until labor starts. And even if they do a C-section, an emergency C-section, the chances of that baby surviving without any problems is very minimal. Very minimal. Because what's happening as that knot's getting tighter, what's happening, that they're not getting oxygen. They're not getting oxygen or nutrients. So it dies. I mean, it eventually dies. So those of you who haven't had me in SIM yet, you'll be able to see a picture of that. Did
She had a C-section.
But she had a section, so she. Yes. And that's how this one was. This one was actually sent to me from one of my former students who had a friend who had a baby, but they had a C-section. See, it would be, so see, like Corey had a C-section, thank God. Because if she had a vaginal birth.
And he was breech, and they had thought about like the week before, like manually turning him, but they just.
Thank God they didn't.
Make that decision, so.
Yeah, yeah. So C-section, and you tell her how lucky he's a miracle baby, because that's what, it's a good thing when they have a C-section, a planned C-section, and there's a knot. That's a great thing because they didn't have to go through that process. So it's very depressing, kind of sad, but I do want you to see this. I did want you to see what this looked like. I'm going to leave the picture up here so that if you can't see it from the back, if you want to, when you're wandering up here for breaks, we're going to take a break, and y'all can come here and see what it looks like. Okay? All right, let's take about 10, 15 minutes, come back, and we'll pick up where we left off. And I'll leave this picture.
Do you know these? I don't know what they are. She just said right now. I mean, I don't know if you want to. Okay.
About what's contained in the sac. We talked about the chorion and the amnion, remember? Now we need to talk about the fluid that is inside the amniotic sac. Remember, there's all this fluid. It's slightly alkaline, and it contains a lot of nutrients. And it does all these different things. The function. Temperature. So, and you know, that's one thing that they talk about. That, bless you. And remember when they, bless you. Remember when the baby was born in the DVD, and he said that you probably won't, you know, that sweet smile that we saw in the utero, we probably won't see again for a while, you know. And they're thrust out into this world that is cold and bright and loud Whereas when they were in the sac, floating around in their fluid, they were nice. They were perfect, 98.6 degrees. It was dark. They couldn't see anything. It wasn't very loud, even though they can hear. And that's one important thing to really to take from the DVD as well, is that a baby can hear in utero. They can hear you, especially the mother. You know, they're able, and they talked about that. The mother's voice and tones really are able to go through the fluid, and the baby can hear. Now, the father's voice or other voices that are around sound more distant because they're not internal as well. But it is important to know that when you talk to your baby, they do hear you. They do talk, or they don't talk back. They do hear you when you're talking to you.
So when people say if you put your headphones on your stomach, does that work?
Yeah, sure does. Sure does. And they can hear the music. Remember them driving the car and the baby was moving to the music? So lullabies and soft music, sweet music does help to calm them down and relax. And
But as far as growth and development, as far as learning like ABC, that don't count.
No. But they just they come out knowing all that.
I mean, not.
I know.
But
Yeah, I know. All right, 2 very important terms for you to know. The first one is right up there. It's oligohydramnios. Very important to know. Oligohydramnios is when there is less than 300 milliliters of fluid in the sac. Now, the normal volume, just to give you kind of an idea of how much is normally in there, it should be somewhere between 800 and 1,200 milliliters. So if there's less than 300, the term for that is oligohydramnios. The problem with that is that that will cause fetal renal abnormalities, so kidney abnormalities. That's what's associated with oligohydramnios. 800 to 1,200. Yeah. Now, of course, and I don't want anybody to text me tonight and say, "Well, my book says it says 700." Well, you know, I'm not going to test you on that amount because, of course, it's going to vary by the size of the person as well, right? That's why there's such a big difference between that 800 and 1,200 and the 300 of oligohydramnios, because you may be a smaller person and have 700 or 600 milliliters of fluid, but it fills the sac. That's why when they do that first ultrasound on you, they can actually guess or they can estimate how much fluid is in that sac. The ultrasound can calculate it out. Those ultrasound machines do a lot of things. And one of the things they do is calculate the amount of fluid that's floating around inside. Too much fluid, greater than 2 liters of fluid. So that's too much fluid. Greater than 2 liters of fluid is called hydramnios. Okay, and that is indicative of GI abnormalities and some other malformations, but specifically GI problems. So too little fluid is renal. Too much fluid is GI problems. Now, one of the ways that they know, not only by ultrasound, but they also know when they measure you. They can actually take a tape measure and they will measure you from the top or the fundus of your uterus, and they will measure you all the way to the point of your pelvis. And that will also, I don't know if you knew this or not, but when they measure you with the tape measure, whatever number that is, should correlate to how many weeks you are. If you're measuring 36 on that tape measure and you're only 34 weeks pregnant, then they start to wonder, maybe we've got too much fluid floating around. Either that or they've got the dates wrong or the baby's large. There's a lot of causes, but one of the things that they look at with those measurements is how much fluid is in the sac at the time. So, okay. What color should that be? Remember, we talked about this. It should be clear. It should be clear, transparent. It should look like water. When the water breaks, it should look like water on the floor.
Is it like cloudy water? Or?
It can be cloudy, and that's okay. It will have a little bit of a cloudy appearance to it, but it should be clear, not colored.
Now, is it viscous or is it?
No, it's very thin. Very, very thin fluid. Like water. It looks like, and I've got a video that we'll watch, I'm not sure when, but it's a little short video, but it has a lady walking in the hall, or maybe she's standing in front of her bathroom. Anyway, her water has broken, and they show, like, the video camera goes, and you can't really even tell other than the fact that it looks like water on the floor. I mean, there's a white floor, and you can't really see anything other than that. So it's very shiny, just like water is and everything. All right, now, there are some colors of fluid that are very concerning, things that we worry about. So it should be clear. It may be a little like, it may have a little bit of a yellow tinge to it, but not much. Have you ever drunk a lot of water and really diluted your urine and then peed, and you can tell that you peed, but it's not? Does everybody kind of know what I'm talking about? Very.
The reason I ask is because when I watched my sister's baby be born, he was big, and when he came out, a lot of fluid came out afterwards, and it looked like you dumped lemonade out. Like it looked like
lemonade.
Like
yeah.
pictures on it. It was like a yellowish.
Yeah, the yellowish tinge to it. And some of that too is going to be the mucus plug, and there may be some blood cells in it too. So, but yeah, it does, when it comes out, it's this massive amount of fluid, and but it should be very clear and very transparent. Okay, green stained fluid is a bad thing. Green stained fluid is indicative of meconium staining. Okay, and remember, what is meconium? Meconium is that very first bowel movement. Okay, so green fluid tells me as a nurse that that baby is in trouble. That baby is in danger. It is stressed out enough that it is pooping. It is having stool in the fluid. Okay, so it should not do that. It should not be having that meconium stool. So maybe there is lack of oxygen. Maybe it doesn't have enough room to grow. Maybe there is a kink in the cord. Something is causing it to be stressed out enough. Maybe the blood pressure of the mother's too high. Okay? Something is causing it to do that. Red, bloody fluid is a bad sign. If the water breaks and it's bloody, that tells me that the mother is bleeding internally. More than likely, that means that the placenta has abrupted from the side of the wall. Okay? Meaning that the placenta, remember, it should be stuck with those villi, remember? Like a little octopus. And at some point, remember, it should not break off. It should not come apart from the side wall until after the baby's born. Those contractions that occur after the baby's born, those help those villi to break, and then the placenta comes out. If those break apart, though, before any of that's occurred, while the baby is still inside, then what happens is that blood starts gushing out, and they start to hemorrhage. And we're going to talk about the different types of abruption later on. So bloody fluid is a bad sign. It could also mean a maternal fetal transfusion, and some of you have had me and Sam already. We talked about the fact that the blood types, when you have O negative and O positive blood and they mix and all that stuff, that's a bad thing. So we're going to talk about that too, Rh factor. Okay. All right. Let's talk a little bit more about the placenta itself and what the purpose of it is. The placenta, the structure and the function of the placenta. So let's talk about this. Okay. the structure of the placenta, it acts as the lungs, the kidneys, and the GI tract during pregnancy. The lungs, the kidneys, and the GI tract during pregnancy. Circulation begins in the 3rd week when the vessels form. Remember we talked about the blood vessels forming in the 3rd week? And then in the 5th week, the umbilical cord. So circulation occurs when the vessels form. Now, it functions as different things. It functions as an endocrine gland, okay, an endocrine gland. And there are some hormones that I know you've heard of before, but we want to refresh our memory a little bit, okay. The first one is HCG, okay. Now, what does HCG stand for? Human chorionic what? Gonadotropin. Where do we find? Where else do we? What else do we use this hormone for? Pregnancy tests, right? Pregnancy tests will detect the level of HCG in the blood. Okay. Now, initially, before the placenta is born, or before the placenta is created, we provide our own HCG. And the purpose of HCG is to prevent miscarriage. HCG provides estrogen and progesterone to the growing baby, the uterus, the endometrial lining. If HCG was not there, if that hormone was not there, what would happen? What would happen to that endometrial lining? It would shed. It would shed, wouldn't it? It would shed, and you would have a miscarriage. The second hormone that's the most important. Let me say something else too about HCG. HCG, when you get pregnant and you've taken your little pregnancy test and it detected the levels of HCG, okay, and then you go to the doctor to confirm it, what do? They draw blood. Okay. The level of HCG in the blood is going to tell them how far along you are, right? Okay. As the placenta is developing, okay, it's not able to do its own thing yet. Remember, the body, we ourselves send HCG until the placenta can provide itself. Before, let's see, I'll just explain this the best. Our body, as a female, provides the amount of HCG to this growing endometrial, this baby in the endometrium, to support the pregnancy. They draw blood. So what they're drawing, the blood that they are drawing, is showing our HCG that we, our brain, our endocrine system provides. Okay? Now, as that pregnancy progresses, that level of HCG is going to go up, because our body, our endocrine system, is providing it. It's giving it away for free. Okay? Now, eventually, in that 5th week, between that 3rd and the 5th week, the placenta develops, right? So the placenta is developing, and it's going to now provide its own HCG. It's going to take care of itself now. So what happens is that if they drew our blood at 5 weeks or 6 weeks, what's going to happen? This is going to be going down. Down, 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 down. Because we don't need to provide it from us anymore. The placenta's doing it itself. Does that make sense? Okay? So that's what they're going to see. The numbers should continue to go up. So women who have had a hard time getting pregnant and who have to have infertility tests and stuff like that, they go, the first week and they say, yes, you're pregnant, and then they're going to bring them back in a couple of days. And they're going to continue watching those levels, and they want to see them rising. If they start dropping off, then what's going to happen? They're going to miscarry. They're going to miscarry. So really important to kind of get that in your head. HCG is provided from us first, and then when the placenta is formed, it does its own thing. It takes over, and it can provide its own HCG.
What effect does that have on weight loss?
It does, and I have no idea. Honestly, I cannot answer that question, but yes, they do give HCG shots for weight loss, and I don't know what it does for weight loss.
Does that not give a false positive?
It can.
It does.
It can. You have a false pregnancy test, and it can also interfere with birth control if you're not careful. Yeah.
So after like the 10th week, if they come back in and get their blood drawn, the levels will be lower?
They should be lower. They should be starting to drop down.
And that is that how they
But that would be expected right at that point. If they come in week 2 and their levels have started dropping down, then they're going to say, you're probably going to miscarry. They can get them prepared.
So is there any reason why the numbers will continue to go up?
Continue
After that?
to go up? Yes.
After that 5th week?
Hydrocortisone mold. Hydrocortisone mold. We're going to talk about mold later. HCG levels that are unusually high when they should have gone down will indicate mold. And I mentioned that earlier in a little bit or later on. That's a good question, Mike. That's why. Okay. The second hormone that you need to know about is HCS. HCS. So HCS, what does that stand for? Human chorionic, a big long word, somatomatropin. That's one of those big fancy SAT words. Human chorionic somatomatropin. Okay. HCS acts as a growth hormone. It is a growth hormone. So it stimulates metabolism. Okay. It also, for the mother, now that's for the baby, it's acting as a growth hormone for the baby, but for the mother, HCS is one of the things that forms lactation, that develops lactation in the breasts.
So it stimulates growth
In the baby.
It stimulates
Increases their metabolism.
Oh, increases metabolism.
Yep. And so if it's increasing, if it's causing the baby to say, woohoo, I need to grow, I need to grow, I need to grow, I need to grow, and get, stimulate metabolism, what is it drawing from the mother? What is it requiring from the mother? Calories and nutrients and oxygen. So it kind of has a twofold effect. Here's this baby, and he's wanting to get bigger and bigger and bigger and bigger. So it also draws more nutrients and oxygen and stuff from the mama, because we're trying to grow, right? So it's acting as a growth hormone. So but it also, in the same turn, is also developing lactation in the breasts.
Does this decrease metabolism for the female?
No. It should increase it, because what it's going to do is it's going to make you hungrier, because you need to get more nutrients to the baby. And but remember, we only need how many calories extra? 300. That seems like so pitiful, doesn't it?
Mm-hmm.
No. Kind of makes you depressed when you think about it. You can't really eat all that stuff that you wanted to eat and get away with it. All right. The other two hormones, because remember I said there's 4, is progesterone and estrogen. Now, HCG helps to send this progesterone and estrogen. Okay, we need HCG to cause these to do what they're supposed to do. So HCG causes the progesterone to help maintain that corpus luteum, that lining of the uterus. Progesterone helps to maintain the lining. Do you remember, and this is really important to tuck back in the back of your mind, do you remember in the DVD at the very end, what did he say? How do we know when birth is getting ready to occur? We don't really know, but what does he say drop? Progesterone drops. Progesterone drops. So that is a very important hormone. If you've got progesterone in your system, what's it doing? It's maintaining the pregnancy. We know that birth is getting ready to occur because that progesterone bottoms out. Okay. Now the problem is that all pregnant women don't go get progesterone levels checked. I mean, we don't. So that's why you don't really. But if you were a test subject, I guess, and they drew your blood all the time, then that would be what they saw, is that progesterone levels do drop. Because we don't need to maintain that lining anymore, do we? We don't need to maintain the pregnancy anymore. It's time for it to be born. Okay. Estrogen, the purpose of the estrogen is to help to decrease the contractility of the uterus. It works along with the progesterone. They work kind of hand in hand, and it helps to decrease the contractility of the uterus. So if those levels are high, the progesterone, the estrogen levels are high, then not only are we maintaining the lining, but we're not having contractions. Now that doesn't count the Braxton Hicks, and we're going to talk about Braxton Hicks later on. But Braxton Hicks are not what we consider true labor. Okay, Braxton Hicks are not true labor. That's just the body stretching and growing and developing and all that fun stuff, even though they're painful on occasion. So the estrogen works along with the progesterone in helping to decrease the contractility of the uterus, because we don't want contractions to occur at this point. True contractions. Right? We also don't want, even though the lactation is developing, we don't want to start lactating yet. And another thing that occurs is estrogen levels drop after birth. And when they drop, not only is the uterus affected, but the breasts are affected. And it will cause milk to be let down. Oxytocin levels increase. We talked about that, Pitocin levels, and that causes contractions. Estrogen levels help the milk to be let down as well. Now, some women do leak, especially if they have a younger child at home. They still leak. Their breasts do leak. But true lactation, the true milk, shouldn't be let down yet. All right, let's look at these. I had 2 more pictures of a placenta. That's that rough side. Anybody get to see a placenta at the hospital? Yep, big old liver looking thing. There's the shiny side. That's the vessels attached. Everybody see that? They look like that. And what do they do when the placenta is born? What do they do with it? They weigh it, and it drops down in that bucket. And then they want to make sure it's all out, so they look at it, right? Did they look at it? Did they show y'all what it looked like? Did Did y'all get to see it? Yeah. See the placenta? And you look at it, and you're supposed to be looking to make sure all the pieces are out. Because if they are retained, it can cause bleeding postpartum. So we want to make sure all the pieces are out. Now, how in the world some of those physicians and some of those placentas can tell that all the pieces are gone or there is beyond me, but they do look. All right. Let's talk about fetal circulation. And I did put a picture on the thing for you, right? You know what we didn't do? We didn't talk about Fyodor Vasilyev's wife. Remember him from Russia? Let's talk about him. Or let's talk about her. The first wife.
Well, I took it in New York, so
She took it in New York. So apparently in New York, they're a lot better off. Okay. All right, now. What we're going to talk about is we're going to work our way through fetal circulation. And you have a picture, a handout with a heart on it and everything. And so kind of follow along with me as we talk through how this works. Now, what is the major organ that is not working while the baby is in utero? The lungs. The lungs do not work while the baby is in utero. And that is very important for circulation, isn't it? Yeah, because it can't get what? It can't get oxygen. So, in our body, what happens? The blood goes to the lungs, it's oxygenated, and then it's returned, right? Okay. Well, we don't have that here because the baby is floating around in this water and the lungs don't work, even though the lungs are developed. And that's something to remember, that the lungs are developed. And you remember at the end of the movie where it showed those shunts closing and the oxygen running in. Did you see that with the little bubbles? Everything closes. So we're going to talk about how this works. We're going to attempt to at least. Okay, so what is responsible for supplying oxygen to the baby? The placenta. The placenta. So it comes from the mama, right? Okay, and here's your placenta. Okay, remember we got all those little hair-like in your projections on there, stuck to the mama. The oxygen is perfused from the mama, through the little hair-like villi, through the vessels of the placenta, through the umbilical cord, right? Through which part of the umbilical cord? Through the vein. Through the vein. Remember, there's only one vein, right? 2 arteries and 1 vein. Through the vein. Okay? And this is what this is showing you. Okay? This is the umbilical vein. Here's what it says, umbilical vein. So, and another thing I like about this picture, I'm not sure if the picture, I think it is, the picture that I gave y'all has, if you print it out in color, you can see the different colors. But the oxygen, the blood that is from here all the way through here is very high in oxygen content because it's coming straight from the mama, right? It's perfused from the mama, comes through the vein. Okay, now, since the baby's lungs do not function, okay, it has to bypass that part of the body. All right? So there are some shunts that close, we hope, after the baby is born. All right? And I'm going to write them up here. We're going to talk about each of those different, they're holes. They're holes in the circulation because when it gets up to the top, we can't go out to the lungs and be oxygenated and come back in. We don't have that part, right? Right? Right. Are you with me? Okay. Yes. Okay. So, the first shunt, the first place that it's going to go through is called ductus venosus. Okay? And ductus venosus is located around the fetal liver. Okay? It's right here. So as this oxygenated blood is coming through, it's flowing right along. Here's the fetal liver. Okay? Okay? So it runs through this hole right here at the fetal liver. Okay, so the umbilical vein, make sure I spelled this right. Ductus venosus. Okay, the umbilical vein enters the portal venous system, which is the portal system is the liver. Enters the system, enters the liver, where it empties most of the blood into the ductus venosus. Okay? Now, ductus venosus connects the fetal liver, or it lies between the fetal liver and the inferior vena cava. Inferior vena cava. Okay? Everybody with me so far? Now, when it empties into that little hole, that little space, that ductus venosus, it loses a little bit of oxygen. Okay? Because there's nothing there again to oxygenate it, right? So as it's going through this process, it's losing a little bit of oxygen here and there. Okay? All right. Now, it flows now into the inferior vena cava. And the inferior vena cava is right here. Okay? Here's the inferior vena cava. All right, so it flows, it dumps into this hole. See, ductus venosus. Flows into this hole. And it joins with the inferior vena cava. Right here. Now, as it's sent up into the first chamber of the heart, it can't go anywhere else. It goes into the foramen ovale. The foramen ovale is a hole or an opening. Let me write this down. Foramen ovale. You probably have that on your picture. Foramen ovale is an opening between the left atrium and the right atrium. That's your second shunt. Left atrium and the right atrium. Okay? You know with me so far? So listen to what I'm saying. The majority of the blood from the inferior vena cava, it went through ductus venosus at the liver, joined up with unoxygenated blood in the inferior vena cava. They all joined together. Okay? And that is sent into the heart from the inferior vena cava into the heart, where it dumps into the foramen ovale. That's the second one. So it's bypassing the lungs. Totally bypassing the lungs. Okay? So from the left atrium, it can't go to the lungs because there's no reason for it to go to the lungs. Now normally, it would go out, right? To the pulmonary artery, remember that? And back in, pulmonary, all that. Pulmonary artery, pulmonary vein, all those fun things. It can't go, it doesn't need to go there. Okay? Now some may go, but it's not going to go, it's not going to do anything. So it's not going to be oxygenated. And you can see the blue up there, that's unoxygenated blood. Okay? There's no reason for it to go there. So instead of it going to the lungs, it spills through that hole between the left atrium and the right atrium. Because think back to anatomy. What normally would happen? From the left atrium, it would go where? Pull a pulmonary vein, two into the lungs, back out, into the right, the right atrium. Okay. Remember, we're bypassing all that. We don't need all that. So it's just going to go from left to right. Just going to go from left to right.
Isn't it an artery that takes it to the lungs? It's leaving the heart, so it's going to the artery, turning the heart by vein.
Pulmonary artery. Vein comes out. Yeah. Okay. All right, so it's spilled from the left to the right. Now, there is another opening called ductus arteriosus. You see it up at the top? Ductus arteriosus. Ductus arteriosus is an opening between the right ventricle, excuse me, back up, between the main pulmonary artery and the aorta. Ductus arteriosus is between the main pulmonary artery and the aorta. Between the main pulmonary artery and the aorta. Okay, once again, most of the blood flow bypasses the lungs and goes into systemic circulation. Blood is flowing in a right to left direction. At this point. Okay, the arteries, it flows into the arteries, back to the placenta, where it's oxygenated, and then it starts the whole process over again. So it dumps from, through ductus arteriosus, it dumps into the pulmonary artery, into the aorta, and out the umbilical arteries. What? Yes, ductus arteriosus is the third one. All right, so there's three that I want you to know. When on the test, I'm not going to make you draw this out or anything. But on the test, I do want you to know that there are three holes and where they are. Okay? Now, let's talk about when they close. All right, you got three. You got ductus venosus between the liver and the inferior vena cava. You've got foramen ovale between the left and the right atrium, and ductus arteriosus between the main pulmonary artery and the aorta. Now, the baby is born. Okay, the head is delivered, and I want you to really pay attention to this when you are in labor and delivery. When you're watching a baby born, I really want you to really pay hard attention. Don't get overwhelmed with the fact that the baby's being born. I want you to pay attention to this part. You know how when the baby's born, they cry? And everybody's like, oh, they're crying. Oh. Okay, before that cry occurs, that baby is going to gasp. And it's so quick that you may not notice it. But it's like an accordion. Okay, if that chest has been compressed through the birth canal, right? It's been squeezed through to get through that birth canal. When that head is delivered and then a little bit of the chest is delivered, what's going to happen? Like an accordion, it's going to go from this, it's going to go like this. And the baby's going to go, and it's so quick that you almost don't notice it. But that is extremely important. That gasp is extremely important because what it does is it takes it from what pressure to what pressure? Positive to negative pressure. Okay? With that gasp, with that first gasp, air starts to flow in oxygen, naked air from the outside environment starts to flow in, and these shunts are not necessary anymore. They become redundant. They're not necessary anymore. Okay? The first one to close is foramen ovale. Okay? The next one to close, almost immediately after foramen ovale, is ductus venosus. And then within 15 hours, and sometimes it may take a couple of weeks, which is why we hear, remember when I was doing newborn assessment, I said in newborns you may hear a little murmur. Remember I talked about that? The reason that you hear a murmur is because ductus arteriosus may still be a little open. That one can take 15 hours to a few weeks. Anywhere from 15 hours to a few weeks it was. Now, have you ever heard of PDA? Patent ductus arteriosus? Anybody have a baby with a PDA? 2 of them? Or is that 2 babies with a PDA? Okay. PDA means that for some reason ductus arteriosus just didn't close. It just never did. Even after a few weeks, it never closed. So that's why, that's what's called a PDA, or a patent ductus arteriosus. And when we do the newborn unit, we'll talk about what we do for that, how to fix that. There are some babies that have congenital heart defects, and I've had them actually up on the unit that will actually have other patent bypasses, like a patent foramen ovale. I'll have the babies with patent foramen ovale. And they have huge loud murmurs. Because if you remember, where's the foramen ovale? Between the atriums, right? Between the left and right atrium. So not only do they have all this blood flowing through back and forth, where it's supposed to go to the lungs and back, what's their oxygen level like? Low. They have a very low oxygen level because it's not all going where it's supposed to go. It's being shunted back left and right. Okay? So babies who have congenital problems, you may see that. Okay. What do you think? Hair, exciting. Yeah, when you finally understand it, it's exciting. You have to sit down and process it because it's so different from what ours is. You just really have to sit down and process it. And I'm not expecting you to be cardiac nurses, so I just want you to know, I mean, you may end up being, I'm not a cardiac nurse, but what I really want you to know is where those shunts are and when they close. Okay? Because my role as a peds nurse, especially in your role as a nurse in labor and delivery and postpartum, is going to be to listen for those murmurs and to see, where is it you're hearing it to and how loud is it? Because even a PDA, even though you're going to hear a murmur, it shouldn't be hugely loud. But a patent foramen ovale is going to be deafeningly loud. Okay. So not only does the gas cause those shunts to start closing, but also the clamping of the umbilical cord. That circulation that was through the cord is redundant now. We don't need it anymore. And so it's clamped and cut. All right? All right, let's take a break. To I'm going to be a mother. There's 3 phases to that. And it really is, that is a very, very important thing. Women who give their babies up for adoption, a lot of those, they don't go through those stages because if they don't bond or identify with this thing that's inside of them, then they don't feel the loss is great. Okay? All right, 18 weeks. Suck and swallow are present. suck and swallow present. And what is he sucking and swallowing? Amniotic fluid. Remember, what did they say about how much a day? Remember, a liter a day? Yeah. Yeah. Sucking and swallowing. Digestion occurs. What is meconium? Do you really know? Well, it isn't poop, but what is it? All that stuff that was floating around in the amniotic fluid. There's hair in there and cells, and meconium forms at 18 weeks. So that black, sticky, tarry substance is what he digested in utero. That's what that is. It's sterile. Did you know that? Meconium is sterile because it hasn't been exposed to bacteria. Do you know why you give vitamin K?
They help.
Yeah, but do you know why?
They don't have their own vitamin.
They don't have vitamin K yet. But vitamin K is produced in the intestines by bacteria. And the bacteria, or the gut, until the baby is born, is sterile. There's no bacteria.
There's no bacteria until it starts to eat.
Exactly, until it starts to eat. Exactly. So that's why we have to give them vitamin K.
Vitamin K is produced by bacteria.
Right, in the gut. That's one of those little side notes for you. That's why you have to give it, to prevent clotting. Did y'all know that? See, you've learned something today. You've learned something today. Okay. So that's what meconium stool is, sterile. And that's why, because there's no bacteria in the gut. All right, 24 weeks. At this point, surfactant is present. Surfactant is present. The eyes are open. And the brain appears mature. Now, what if a baby was born at 24 weeks? It's, the lungs are not fully mature, even though surfactant is present, and surfactant is very vital. Because what does surfactant do? Keeps the lungs from sticking to each other, keeps them open, it keeps that pressure regulated in there. And so if the surfactant is not present, or enough of it is not present, maybe some of it's present but not enough of it, are they going to be able to survive without being on a ventilator? No. So before 24 weeks, babies who are born before 24 weeks have a very low chance of survival. And if they do survive, they tend to have a lot of issues, a lot of problems. Okay. Do we have 20 and 22 weekers in the nursery? Yeah, we do. We have a lot of them. Those babies are there for a long time, and they have a lot of problems. A lot of problems. And of course, everybody's going to know somebody who had a 20-weeker and they look great and everything's great. But that's not always the case. Those are rare cases. Rare, rare, rare cases. So you really don't want a baby born. Definitely you don't want them born before 24 weeks, but you really don't want them born at 24 weeks either, because they still have issues. They still have problems. So, but surfactant is present. They have seen that surfactant is present at 24 weeks. All right, 28 weeks. The nervous system starts to regulate function. So the nervous system starts to regulate function. Okay. Nails, eyebrows, and eyelids are present. And that's something else we didn't really talk about at 24 weeks and earlier. They don't have eyelids like we do. It's just like a little membrane that comes down across their eyes. they're still developing and growing. They don't have nails that have formed yet. So I'm telling you, there's a lot of problems with those babies. Okay. 32 weeks. Now at 32 weeks is about the time, about the earliest that we can see, 30, 32 weeks, somewhere around there, that we can see a baby born without much necessary intervention. Now, they may need some, but not as early as your 20 to 24 weekers. 32 weeks, they have sub-Q fat. And what's that important for? Warmth. Again, before that, they can't regulate their temperature. So sub-Q fat's deposited. They get their own iron stores. Okay. And delivery position is assumed. We hope. Now, what that means is that he's about done with his flipping and flopping around. So whatever at 32 weeks, whatever position they are in is probably the position they're going to be delivered in. So that's about the time when they discover if you've got a breech. Now, like with me, they discovered Ben was breech from the beginning, and he never turned, never flipped, never did anything. But some babies who've been flipping the whole time, they get breech. Their butt goes down and they get engaged down in that pelvis, and then you can't do anything about it. So before 32 or about 32 weeks, if they see that baby as breech, then they may try to turn him. I don't ever recommend anybody doing that. It is very hard on the body. It's very hard on you, and it can cause preterm labor. And it's not a guarantee. You could go in and, it is painful to have a baby turn, because what they do is they stick their hand up inside and then they push on the outside, and they're manipulating, like they're making this baby turn. They're forcing him, to turn, and then there's not a guarantee that he's not going to flip back. So you may have gone through all of that for nothing. So,
And if they have a knot,
and then if they have a knot and they get head down and they're delivered, then we're in even bigger trouble. So yeah, it's just not good. Okay, and then at 40 weeks, a baby who's born 40 weeks now has vernix in the skin folds, which is that like cheesy-like substance. That's a product of the oil glands, the sebaceous glands. Keeps them moist and not dry out. The skin has a smooth, polished look. The hair is about 1 inch long. They have hair. And they now have creases on the soles of their feet. Did you know that those didn't develop until later on? It's interesting if you're in the NICU a lot and you follow a baby over the course of several weeks, if they're born at young, like 24 weeks, it's interesting over time to see these things growing outside the body. Like the nails growing and the creases developing on the feet. And the eyelids start to, it's interesting. It's fascinating to see day to day their development, to see how they grow and develop outside the body. And of course, that's not where you want them to be. You want them to be that nice, protected, warm, safe environment. So this is very important, these little things to know. Now tomorrow when we first get started, we're going to do a little activity with these things.